My name is Lamia Huck, and I'm a hepatologist and addiction medicine physician caring for patients in New Haven, Connecticut, and I direct the Clinic for Alcohol and Addiction Treatment and Hepatology at the Yale School of Medicine. In the next few minutes, I'll review some key points in treating alcohol use disorder in the context of liver disease. Liver disease is one of the most common medical complications of alcohol use disorder, and in recent years, it has become the leading cause of death due to alcohol. The treatment of alcohol use disorder in the context of liver disease is critical, and it can have a huge impact on patients' survival, as well as the ability to prevent the progression of liver disease. It can reduce complications related to liver disease, and in patients in whom liver disease has not yet developed, it can reduce the likelihood of even developing liver disease. So it's really important for us to think about how to offer patients with liver disease the full spectrum of medications as well as treatments for alcohol use disorder and how to safely do so. When we think about whether liver disease impacts the way in which we treat alcohol use disorder, it's important to think of the severity of the liver disease and how to categorize it. Liver disease, just like many other chronic conditions, is something that occurs on a spectrum, and there are early and later stages. In general, when it comes to alcohol associated liver disease, there are multiple risk factors that can affect whether a patient progresses through the various stages of liver disease. Certainly, at any stage of liver disease, reducing or eliminating alcohol can have an impact and can improve or reverse some of the injury associated with the alcohol. We think about alcohol associated liver disease in four broad categories to try to help us determine whether we need to modify how we think about medications for alcohol use disorder in this context and how to best counsel our patients and choose medications that would be the best fit for them. The four broad categories of alcohol associated liver disease would be early alcohol associated liver disease, advanced liver disease, alcohol associated hepatitis, as well as decompensated alcohol associated cirrhosis. So, going through them one by one, early alcohol associated liver disease, typically patients do not have symptoms at this stage, and it really refers to early or milder forms of liver injury due to alcohol, which can include fat accumulation or mild forms or early forms of scarring or fibrosis. In advanced liver disease, this is where liver injury typically has been more chronic, and we see that there's more scarring that's occurred. And this can also include patients who've developed cirrhosis, but in the compensated stage. In this category, patients are also often asymptomatic, as they are in the first category, but there may be some signs in their laboratory testing that there could be advanced liver disease or cirrhosis. In the third category, alcohol associated hepatitis, this is less common than the other two categories that I mentioned, but it can be severe. And this is a severe inflammatory consequence of alcohol in the liver, where patients may develop jaundice and have other symptoms. And depending on the severity, patients may even need to be hospitalized and may develop liver failure. In the last category, decompensated alcohol associated cirrhosis, these are individuals, again, who are in a more severe category of liver disease where they now have symptoms of liver disease. They have complications of cirrhosis, and they include most commonly ascites, which is fluid accumulation in the abdomen, hepatic encephalopathy, which refers to cognitive changes and neurological changes related to advanced liver disease, as well as bleeding from the gastrointestinal tract from things like esophageal varices, as well as other complications. In this category, patients may also be at a higher risk of liver cancer and can also progress to acute on chronic liver failure. Medications for alcohol use disorder should be considered at any stage of liver disease. And in general, if we think about what the possibilities and options are in each of the stages of liver disease, in early ALD, the first category, really any medication from a purely liver standpoint, any medication is felt to be an option for patients. And that includes the FDA-approved medications, naltrexone, acamprosate, or disulfiram, as well as the off-label medications, topiramate, gabapentin, and baclofen. In the second category, advanced ALD, or advanced alcohol-associated liver disease, again, most of the medications that are available for alcohol use disorder are options. The one medication that there is some caution that should be exercised is disulfiram. The reason for this is that disulfiram, in rare cases, is associated with a significant fulminant liver injury that can, at times, in rare circumstances, be life-threatening. And so, because although it's not more likely for patients with advanced forms of liver disease to develop liver injury from disulfiram, the consequence of a severe liver injury would be greater in a patient who already has other underlying significant liver injury. So, for that reason, in this advanced liver disease category, caution should be exercised with this medication, and it should really be reserved for patients in whom other options are not available. There's very close monitoring and kind of in select cases. In the more severe categories, acute alcohol associated hepatitis, as well as decompensated alcohol associated cirrhosis, again, the thinking is similar, where disulfiram in these cases really would be strongly discouraged, and most hepatology specialists would say to avoid completely. Other options for alcohol use disorder treatment, such as acamprosate, naltrexone, gabapentin, topiramate, and baclofen, may be possible, but there may be some considerations that need to be taken. So, for example, for acamprosate, patients who have liver disease that is as severe as these second two categories oftentimes can have kidney injury. And so one would have to be mindful of the kidney function when prescribing acamprosate, and either reduce the dose or not be able to prescribe it if the patient's kidney injury is severe enough. Acamprosate does not have any concerns when it comes to liver injury, but a complication of severe liver disease is kidney injury, which is why sometimes this becomes an issue in these categories. With regard to gabapentin, topiramate, and baclofen, these medications to varying degrees are associated with some cognitive effects. And so patients can sometimes have hepatic encephalopathy when they have decompensated cirrhosis or severe alcohol-associated hepatitis. And in those cases, especially if the hepatic encephalopathy is not well controlled or is a significant issue for the patient, one would need to be very cautious when starting a medication that can further impact cognition, which is why these may not always be the best option or may need to be monitored very closely if started. Naltrexone is a medication that there has been a shift in the thinking, and also historically been some hesitancy and confusion when it comes to liver disease. So, in general, what we know now is that there have been multiple observational studies that have shown that naltrexone may actually not be associated with significant liver injury, even in patients with advanced liver disease, such as cirrhosis or decompensated cirrhosis, that in many or several large studies, patients who were started on naltrexone, who've had underlying cirrhosis, there actually were no cases of liver injury that could be attributed to the naltrexone. And overall, in general, receiving medications like naltrexone is associated with an improvement in liver health, as well as an improvement in survival. And so I think at this point, the thinking about naltrexone is that in most patients with cirrhosis, naltrexone is a reasonable option. One might consider some caution in patients who have Child-Pugh C cirrhosis. So the Child-Pugh categorization is sometimes used to categorize patients in with cirrhosis, from A, which is the least severe form, to B, to C, which is the most severe form. And Some feel that in patients with child PUC cirrhosis, there should be some degree of caution with any medications that are hepatically metabolized, which include naltrexone. And so, in that category, one might monitor the patient more closely. In general, if a patient's liver enzymes are rising, or if the liver disease is rapidly worsening, then one may consider avoiding naltrexone until the liver disease has stabilized or there's sort of some understanding of the trajectory, and maybe use a different option, such as acamprosate if possible, or a different option in those cases. And I think that in general, this is an area where there's ongoing investigation to determine whether, in the most severe forms of liver injury, where somebody is hospitalized or have severe acute alcohol associated hepatitis, if naltrexone is safe in those cases as well. So overall, I think that the main points are that it's important to categorize patients with regard to the severity of liver disease and to look at the patients holistically rather than just focusing on a few different laboratory tests or the thresholds for whether a patient's liver enzymes are at a certain elevation, rather to determine whether a patient falls into the earlier or the more advanced stages of acute and chronic liver injury, and to think about which medications might be appropriate for them based on those categorizations. In addition, it's important to think about the benefits of treating alcohol use disorder at any stage of alcohol-associated liver disease, and to think about treating alcohol use disorder in this population as weighing the risks and benefits. Many times, the risk of ongoing alcohol use and alcohol exposure to the liver outweighs the possible rare risks of injury to the liver from medications like naltrexone, for which now there's evidence that that suggests that that risk may be very low, or not a risk at all in certain cases. So I hope that that is helpful, and thank you so much.